Turning on the switch, the first thing. And I think that's in a way what we do with many of the clients we work with IMR. It's almost like helping them turn on the switch. That for many of the people we've been working with, they've been quite withdrawn and quite uninvolved in the world. And turning on the switch, giving the power, is a lot of what IMR is about. So I just want to pick up a little bit where we left off. We talked about the setting of goals and how it's important to find something that's truly meaningful for the person, but it's no good if we don't follow up on those goals. One of the clients that we worked with during the development of IMR said, goals, he said, that's what they use to hit us over the head. I said, what do you mean? And they said, well, when we get to do these treatment plans with the treatment team, they say, what do you want to do? And I say, I want to get a job. And then 6 months later, they ask me, well, did you get a job? and they say, well, no, I'm having a little trouble. Well, why aren't you getting a job? And it was as if by setting a goal that was truly meaningful and might be a little ambitious, they were in a way punished or embarrassed. And instead, we thought it was really important to be, so where were those treatment providers in that 6-month period? It's that follow-up, it's that every day that we work with folks that we want to really be moving that goal forward. So we want to check on progress. When you're working with an individual, we usually say every week, you check on how's it going with that step that you were working on? What happened when you looked on the internet for different places you could go for fun for free? Showing an interest in the person's goals and asking how it's going is very motivating to the client. It's very motivating to us. Keeps us going as well. So in a group setting, we say at least once a month, you check in with goals on a rotating basis. So if these 4 people were in my group, 1 week I would check in with one person, 1 week I'd check in with the next, 1 weekend with the next, 1 week with the next, and then turn it around again. So that it's not, doesn't take up the whole group, but there's a frequent check-in on goals. And we want to be able to reinforce the steps that were taken, and if they're coming up with challenges, let's help them solve those challenges rather than just keep moving on. As Kim was saying earlier, in IMR, the goals are what holds the whole thing together. It's like the glue. It's the thing we always ask when people say, well, this client's not making progress, or this client's not participating well in IMR. We say, well, what's the person's goals? And what is it that we've helped them to see in terms of progress towards that? So if we don't have that glue, it makes it very difficult to implement IMR. And without the personal goal, it becomes just another program, I think. It makes it just another sort of approach to working with clients that does not involve the client, as the woman earlier was saying, eye to eye. It keeps us eye to eye. Okay, additional ways, in addition to goals, that we think you all as clinicians empower the clients is that you're inspiring hope in a concrete kind of way. This is one thing that when I first heard about recovery and the goals of recovery, I was having a hard time conceptualizing it. And one thing with IMR, it puts it in more practical terms, is that we're inspiring hope, but we're also basing it on something. We're saying we're hopeful that you can achieve this goal. We're hopeful that you can take this step. We're very excited to see you make this progress. It's that kind of concrete reinforcement that really helps. And then I would emphasize that another way that we empower the clients is through teaching skills. It's not just about knowledge, it's about a skill, strategies and skills that people can put into action. And that's why I think it's so important in IMR to really make it lively. Something where you're really learning something and you're practicing it and you're role-playing it. And if it's a group, people are helping each other out with that practice. Okay. So Kim is going to talk a little bit about who can benefit from IMR and why, because we've talked a bit about what are the main sort of parts of IMR that make it powerful, but then we want to think about who really benefits from IMR and how can, and why. So Kim is going to take over.
So IMR was developed originally for people with schizophrenia spectrum disorders and major mood disorders whose disorders were severe enough that it was really interfering with their day-to-day lives. And so the educational curriculum, in particular the curriculum about the disorders, was specific to those particular disorders. However, IMR can be adapted pretty readily to a wide range of other psychiatric disorders as well, including post-traumatic stress disorder, obsessive-compulsive disorder, and borderline personality disorder. We're often asked the question of, can you provide IMR to these other particular groups? And to give you a little bit of a story, I was in Taiwan, I think 3 or 4 years ago, and Taiwan had a translation of IMR into Chinese, and I was down in the southern part of Taiwan, and there was kind of an evening colloquium, a group of different people getting together, talking about experiences with IMR. And it started off this man who I think was a parent, a family member, because there were consumers and family members there. And he started talking, and he was talking in Chinese in a very impassioned sort of way. And I was rather worried. I thought that he had a problem, with IMR because there was a little bit of annoyance in his manner, and somebody was providing a translation. And what he was saying was that, what do they mean, illness management? These are life skills. Everybody needs these skills. And I think that there's a lot of truth to that. When you look at what is in IMR, you have building social support. You have coping with stress. You have the hazards or choices to make around using substances. You have coping with symptoms, but of course, many symptoms are part of day-to-day life. I mean, depression, anxiety, these can get out of hand, and they can become symptoms. But they're also life experiences, even things like hallucinations. We know that all of these things happen as a part of normal life. And so, from a particular perspective, IMR contains a lot of ingredients that are really life management skills. And from that perspective, the basic framework of IMR, in terms of here's a set of life management skills with some specific information about particular psychiatric disorders, the principles of treatment. If you look at IMR from that perspective, it can be adapted as needed to really a wide range of different populations. And before the break, I had mentioned there's actually a series of substance abuse treatment residential facilities in the Philadelphia area that a colleague of ours has been providing consultation for the implementation of IMR across these different substance abuse agencies. And in all of them, the participants in the IMR groups are people who have an addiction. Now, we know that among people who have an addiction, about 60 to 70% of them also have a psychiatric illness. But 20 or 30% of them don't have a diagnosed psychiatric illness. But these groups are just for anybody with an addiction who wants to participate. And people are finding lots of value in it. So from that perspective, you can really look at IMR as a tool that is broadly applicable to other disorders and where you may want to create additional educational curriculum when you have another disorder that a person has in order to provide them with information about that disorder so that they can participate in decision-making and ultimately that they can end up making the decisions about their own treatment. I mean, that's really what it's about. Where can IMR be provided? Well, by now you know it can be provided in a wide range of different settings. There's no real limitation to where it can be provided. Let's just talk for a couple minutes about providing IMR to challenging clients. People often say, or sometimes ask, who can you provide IMR to? Or do you need a certain level of motivation or a certain level of recovery or a certain level of cognitive functioning in order to participate in IMR? And our answer is always, no, you don't. That IMR is an approach, it's a tool that you can use in a systematic and clinically sensitive way to help people, wherever they are in their mental illness and in their lives, begin to move forward. And so there are no particular limitations. Some people can benefit from the exposure to IMR curriculum more than once. Some people benefit from exposure just to some IMR curriculum. We'll be talking about that a little bit later. But the idea is that, sure, there are people who seem to have low motivation, and they may be more difficult to engage. And so what you try to do is to use your clinical skills and your flexibility and your sensitivity to where they are in order to kind of capture their interest and to make a connection with them, even though they may be at a very low motivational state. Sometimes when you're working with people who seem to have low motivation, figuring out where they are and what their needs are. You know, we emphasize helping people come up with personal goals, personal recovery goals. But sometimes the best way of connecting with somebody isn't by trying to engage them around their goals. It's to engage them around their needs. They may have very practical needs. It could be housing needs. It could be they're suffering from the throes of severe depression. They don't want to talk about recovery and what their goals are. You know, they want to have some way of getting up in the morning or some way of having a sense that there is a possibility. And they may have much more rudimentary, much more basic needs. And you may be able to help them address those needs by seeing where they are in that particular situation. Sometimes when people have very low levels of motivation, you get very little follow-through on the goal work. And Susan was talking about sometimes clinicians have used goals against people. That if somebody sets a recovery goal and then they don't take a step towards that recovery goal, that somehow it's an indication that they don't really want it or they're not motivated enough. Whereas we know that having the wherewithal, having the cognitive ability, and having the belief that your life can be different if you take a step towards a goal, that takes a certain leap of faith, right? I mean, whenever you work on achieving something you don't have, first of all, you're taking a risk. You might not succeed. And second of all, you're spending a lot of energy and effort, and some people don't have that. And so what you need to do is, with yourself, with your enthusiasm, with other people, with support of other people, with members of the team, you need to create what Patricia Deegan calls a conspiracy of hope. This sense and this help around the person that helps them take these next steps towards their goals. So involving significant other people in knowing what the goals are, in planning, helping the person take steps towards the goals outside of that IMR session, that becomes part of this conspiracy of hope, where everybody around the person is hopeful. Even if the person's not hopeful, that's okay, you know? You need to be hopeful. You need to get other people on their team who are hopeful. You need to make their family members hopeful, and not just sitting back and, well, I really hope something happens, you know, but stepping forward and saying, hey, let's go out. Let's go and do this together. And so this hope around people is what eventually infects people themselves with a sense of hope. Hope combined with the practicalities of helping people make steps towards their goals. So that's part of the idea of kind of engaging, working with people on who have low levels of motivation. A couple of other ideas. how many people have seen, you can just raise your hands, no verbal commitment required. How many people have seen the introduction to IMR film starring Susan and many consumers? Okay, a few people. Okay, so first of all, this film, it is in English, but it's pretty easy to follow. It's available on YouTube. We can tell you how to find it on YouTube. But it can be watched. It's about a 15 or 20-minute introduction to what IMR is, mostly told in the words of consumers, mental health consumers themselves. Many of them, people who Susan and I have worked with, who talk about what recovery has meant to them, and who talk about how learning how to manage their own illnesses have helped them work towards recovery goals. And it's not set in a clinic mostly. It's in clients' homes. There's one client, David Keim, who people may be familiar with because he has contributed parts to IMR. There's one part where he gives a tour of his apartment to Susan, and he's an artist. And he has this very interesting art. At one point, he dons this whole suit that is a bird suit, and it's filled with these, covered with all these feathers on top of it. And he's kind of talking about how learning how to manage his illness has enabled him to move forward with his art, and how doing art is a part of managing his illness. So, watching this movie together with the consumer, and just watching about it, talking about it. If you want, you can stop every once in a while if you need to translate with the English. But it just becomes another way of getting dialogue going, of getting people talking about how their lives could be different. And the images can be very captivating, especially David Keim wearing his bird suit, but other ones as well. And that may get consumers talking about things. One of the other consumers in the film plays the piano. And he was actually a graduate of the Berklee School of Music in Boston, very well-known school of music before he developed schizophrenia. And he talks about how, even with all of his relapses and in and out of the hospital, how music was always there for him. And he talks about the importance of that. And over the many years since learning illness management, he's ended up marrying his girlfriend from high school. He's had 2 kids. He teaches music, and he works as a janitor. He still has symptoms, but this becomes a way of getting people to think and to talk about how things might be different. And so, again, it's a very low, when people have low levels of motivation, one of the really important things to do is for you to have low levels of expectation for how much work they need to do at a particular time. You want to make it as easy as possible to kind of get them going, to take a small step forward. It's not that you want to have low expectations. It's what you want to do is you want to have expectations for low levels of involvement on their part in order to kind of connect with them and get them going. And so watching movies, doing things together, walking around, all of those can be ways of kind of giving people a way of connecting with you that have kind of low levels of expectation for what a person needs to do. I'm not going to go into the details of this. We have a couple of slides with just examples of how to engage people verbally. I'll read one of them, and you'll get copies of these slides later on so that we can move on. But the first is, I'd like to tell you a little bit about a program I think you might be interested in. This program is called IMR, and it focuses on helping people make changes in their lives that they want to make and achieving personal recovery goals. The program's also aimed at helping people learn how to manage their illness more effectively and to prevent it from interfering with their goals. This is just kind of an example of how to introduce IMR to anybody, wherever they might be at. And we have other kind of examples of this. But the idea being that IMR really can be provided to anybody regardless of their level of motivation or where they are. A couple of other strategies, just getting to know the person. Sometimes when people have low levels of motivation, it's really important not to have an agenda of a lot of things that you want to accomplish. Being able to spend time getting to know someone can be really a critical thing. And sometimes what happens is that process of getting to know somebody just happens to lead into identifying something that perks the person up. It could be something about music. It could be interest in poetry. It could be that they know sports or something. But you wouldn't have known it ordinarily if you hadn't just spent a little bit of time getting to know the person. Sometimes taking the focus off of the here and now, talking about the past, finding out things that they enjoyed doing in the past, things that they wanted to be, ambitions, and things like that. One other thing is that a lot of clinicians think that because of the importance of goals in IMR, that every goal has to come out of the client's mouth. And if the client didn't say it as a goal, it doesn't count. And that somehow you have to elicit the goal verbally from the client. And it's just not true. The idea of IMR is that people are motivated to pursue their own goals. How you help people come up with goals depends on your own creativity as a clinician. If you get to know somebody really well, and you know that they really care about something, and you say, well, how would you like X? And they say, I would like that a lot, that's great. You have a goal. So it's perfectly fine for you as clinicians to be actively involved in helping people set goals and even to suggest goals. The idea is that you're not suggesting a goal because you think it would be a great idea. You might suggest a goal because as you've gotten to know the person, you've gotten to know their values and what they care about, and the goal that you're suggesting seems to be consistent with that. And we can be comfortable with that, right? I mean, we don't have to be so rigid that we're not allowed to say something. We have ideas. We get to know people. We can make suggestions. It's important that we're not imposing our own values and beliefs and things like that. But just because they're client-oriented goals doesn't mean that we can't be actively involved in helping them identify them. And the same thing when it goes to breaking them down. We sometimes hear from clinicians, clients, they're so terrible at breaking down these goals into short-term goals. Who go, yeah, it's really hard. Maybe you should help them more. Yeah? So it's fine. The idea behind IMR is that the motivation to learn how to manage your illness comes from how it's going to help you achieve goals. So it's important to have goals that you really care about. But how you come up with those goals and how you break them down, there's no one way of doing it. And clinicians usually need to be involved in helping people set those goals based on what clients want, based on what the changes are that they want in their lives. So what we're going to do in this section is, at the beginning, talk a little bit about tailoring, adapting, modifying IMR to meet particular needs and circumstances. And then we're going to talk a little bit about sustaining IMR. How, after you implement IMR in a particular setting, what are the factors that contribute to keeping it going and growing? IMR is kind of like a plant, you know, which is, it's not like a piece of furniture that you don't put it into a setting and just hope that everybody uses it. It's a plant, and so it needs to be tended to and gardened and, fertilized and things like that. So we came up with definitions to distinguish between flexibility, tailoring, and adaptation. We just thought it might be helpful. But when we think of using IMR flexibly, what we think of is we've got the basic IMR program, but there's different ways of using it. And the different ways of using it are a reflection of its flexibility. We think of the tailoring of IMR has to do with how it's implemented differently to meet the needs of different people. But you're not necessarily modifying what's in IMR very much, but you're modifying how you're using it. And then we think of adapting IMR as when you do make some modifications in the program itself. This will become a little bit clearer. So flexibility has to do partly with the format of the implementation. So you could teach IMR individually or in groups. You can combine those. And then we'll also talk a little bit about what we call the targeted use of IMR. So one thing is that the order in which you teach IMR, there's a particular order: recovery strategies, basic facts, stress vulnerability, but you don't have to teach the curriculum in that order. In most cases, we think it's important to start with recovery strategies. But if there are reasons to teach another module after recovery strategies, once people have their goals, there's no reason not to. A person may be experiencing a lot of stress, and so you go immediately to stress. Or the person might be having symptoms of anxiety or trouble coping with voices, and you might go immediately to that. Or a person might be having prominent substance use problems, and so maybe you'll go to that one first. So you can use the curriculum of IMR flexibly. You don't have to teach it in a particular order. And then, as people may know, people who do IMR in groups, when you do IMR in groups, you can have a closed-ended group, closed membership, where you have everybody starts IMR and ends IMR, going through the same sequence of curriculum. Or what you can do is you can have an open enrollment format. And in an open enrollment format, new people can join the IMR group wherever it is. When you have an open enrollment group, what you do is you have an individual clinician meet with the client who's going to join the group, and you have that person do the recovery strategies module first, so that everybody has a personal goal. And then they join the IMR group wherever they are. And the IMR group, it could be in the building social support module. And they join the building social support module. And when the group comes to the 11th module, they start over. They actually go to the second module, basic facts. And they keep revolving around the curriculum so that a person can join the group at any time. And so that's a reflection of the fact that the curriculum, the order of the curriculum, can be changed for people participating in IMR. Let's just talk briefly about IMR individually versus groups. Some of the advantages of individual IMR are that it's easier to tailor it to each person. You can integrate it with case management. You can adapt it to the person's learning style. There are certain settings, like in more rural settings, where it's very difficult to get groups together. Doing IMR individually may be more practical. In the US, in certain states and certain settings, implementing IMR on an individual basis is the norm. It's usually done on an individual basis. In other places, it's usually done on a group basis. But places that provide it in a group basis often need to have the flexibility to provide it individually for certain clients who may have trouble keeping up with the group, or where logistically it may be hard for them to meet with the group. Some of the advantages of doing IMR in groups: there's more opportunity for peer support, the sense of recovery and what it means, and people supporting each other and working towards that. There's more role models and opportunities for feedback, maybe more economical. There's more opportunities for co-leaders. When you have a group of IMR, an IMR group going, having a new clinician join the group And you can also have consumers, peer support people, join groups and learn how to co-facilitate a group after they themselves have had the experience. All of that becomes much easier to do in a group format than individually. And sometimes combining individual and group makes sense. You may have clients who have a lot of symptoms, or they may have cognitive impairment, where they can benefit from participating in groups, but they may have trouble keeping up with the group. And so being able to do some individual work to help make sure the person keeps up with the group may be the most flexible way of helping the person get the benefits of the peer support from the group, but make sure that they don't fall behind in terms of the progress towards their goals and the learning the illness self-management. One other thing is that in groups, especially if you have large groups, let's say 6 to 8 people, it's very difficult to keep up with everybody's goals with 6 to 8 people in a group. It can be done, takes very, very organized and disciplined leaders to do that. Sometimes having individual meetings with each person, say once a month or so, becomes a way of making sure that you're tracking each person's goals as they're progressing, as they're participating in the IMR program. So again, these are all examples of flexibility in terms of how IMR is implemented. So we're used to thinking of IMR as a program, this whole program, the 40 to 50 sessions, setting personal goals, learning how to manage your illness in order to achieve those personal goals. But sometimes people have needs that IMR can help them address in a much more targeted fashion. And so we refer to targeted IMR as when you're using a part of IMR in order to address a critical or pressing need that a person has. And the idea of targeted IMR is that IMR contains a wealth of information and skills, as well as ways of helping people articulate goals and so on. But sometimes what a person needs is a very particular set of skills or self-management strategies to address an immediate need. And that as clinicians, what we need to do is to help people address those needs first. And then we can see about whether we can engage them and they want to participate in IMR after that. But really what we need to do is address that immediate need. So for example, if somebody is in the throes of depression, they've got very, very serious major depression, you can't engage them around goals, they don't want to come into a group, they're extremely despondent, maybe it's hard to get out of bed, maybe they're racked with anxiety. And what do we know about IMR? Well, we know that there is a whole module that contains coping strategies for helping people deal with depression. And so the idea of this is that if somebody is in the throes of depression, you don't try to engage them around recovery, you don't try to get them into a group, you try to help them cope with the depression. And so you go right to the coping strategies with depression. And maybe you use a handout and you try to help them figure out a coping strategy, or maybe you don't use a handout. Maybe you know what the different coping strategies are, and you go in, and maybe you select a particular coping strategy, and you start engaging the person around trying to implement that strategy, such as behavioral activation, the scheduling of pleasant events. You go and you work with a person and a significant other to schedule some events for them to participate in. Or maybe you're going to select something in terms of challenging negative thinking, kind of the beginning of CBT around depression, and helping them challenge the negative thinking and thinking more positively. And what you do is you use the curriculum, the coping skills for managing depression, and you try to use that systematically, with or without handouts, whatever you think is the most effective way in terms of giving the person some practical tools for coping with the depression. Now, once that's done, then you can begin to explore, do you want to engage the person? Can you engage the person around recovery strategies, making goals, beginning to establish goals, and if you can, great. Why not move forward? If you can't at that particular point, that's okay. There may be another point. Maybe there's another practical need that they need help on, and maybe there's a lot of stress and they can benefit from learning some stress management strategies. But the idea of targeted IMR is that the IMR curriculum contains a wealth of strategies and skills that can help people manage their psychiatric illness. And it's perfectly fine to use those specific strategies in a very targeted, specific way in order to help people meet immediate needs that they have, especially when you can't engage them in the broader goal of working towards a recovery. So there are other examples of this. Severe substance use. Let's say a person has recently had a relapse, they've come out of the hospital. You may actually engage them in IMR more effectively by helping them develop a relapse prevention plan to prevent them from having to go back in the hospital. That may be your entree, your best engagement strategy for working with the person. And as I say, if that goes on to then helping people develop personal recovery goals and make steps towards them, that's great. But even if it doesn't, you're still doing justice to working with the consumer. There will be other opportunities to engage them around the recovery vision. And so that's the idea of targeted IMR. Just as an example, this is a client who was 50 years old, was receiving assertive community treatment services. She had diagnosis of depression. When she was beginning IMR, she had very, very severe depression, couldn't leave her apartment, wasn't taking care of herself. And so the ACT team focused on approaching her around strategies for coping with the depression. And then following that, added strategies for building social support, and eventually used these practical ways of helping her address her needs for engaging her around achieving personal goals based on her ideas of recovery. So tailoring IMR refers to when there are modifications in terms of how IMR is implemented, even though the basic curriculum of IMR is relatively unchanged. So IMR has been implemented in homeless shelters by Center for Urban Community Services. And in that way, everybody beginning IMR really had a common goal of getting stable housing. And there's another example, I think on this slide, of where IMR was implemented in an agency in Brooklyn where everybody was engaged in supported employment services. And so here the tailoring of IMR is partly related to the fact that everybody has a common recovery goal. Now, the goals are still broken down into specifics, and the nature of that goal is individual, but there's a certain convenience to when everybody wants stable housing or when everybody wants to get a job. It makes it easier to come up with common reasons for how illness management may help people achieve their goals. When IMR is implemented in state hospital systems or long-term inpatient settings, there are needs for adaptations for how IMR is implemented in order to get the broad base of support necessary to make change in an institutional setting. So a principle of IMR really has been the engagement of significant others, like family members. But when you're implementing IMR in the state hospital system, people don't have as much contact with family members. Who do they have contact with? They have contact with psychiatric aides very often, people who see them on a regular basis. Often they don't have a high level of education. Often they don't have a lot of clinical training. But these are the people who they see every day. And so these people then need to be brought in and made a part of the greater IMR team. They need to have education about what IMR is. They need to be involved in regular meetings so they can be actively supporting clients in terms of making steps towards goals and learning illness management. So that's just an example of an adaptation to how IMR is implemented in a state psychiatric hospital. And when IMR is implemented on assertive community treatment teams, you similarly need to have the goals that people have, that they're working towards in IMR. They need to be discussed by the whole team in regular team meetings. And the opportunities for people to practice skills in IMR. You need to have team members figure out who is going to work with a client to do that. So these are just examples of tailoring adaptations for IMR. I think that we should skip this part. You can look at the slides eventually. But this is the a kind of a more detailed experience of implementing IMR on assertive community treatment teams. And this has been part of a research study that Susan and I have been involved in over the last 3 or 4 years, and the work is continuing. I'm not going to go into a lot of detail, but what these slides describe is a series of processes we went through in figuring out how to implement IMR on assertive community treatment teams. And what we will do is you'll get a copy of the PowerPoint, and we can also send a copy of a paper that describes the actual results of this research study, showing that we can implement IMR on ACT teams, and that in a small controlled trial, showing that the people who are on the ACT teams who got the IMR showed greater improvements in illness management, as well as other areas of functioning. This goes into a lot of detail here, as you can see. Right. And were you talking this part? Okay. So now I'm handing it back over to my capable co-presenter.
Yes. Okay. Yes. And this is an area that I have a special passion for, is that there are some populations of people that have been neglected by our mental health services because they are kind of challenging to work with. And we did some adaptations of IMR that were really focused on some of these individuals. One is a program where we integrated illness management and recovery for psychiatric disorders with illness management and recovery for medical disorders. So kind of interweaving, how do you manage diabetes? How do you manage high blood pressure? How do you manage cardiac disorders? Things that are, as you know from working with people with severe mental illness, that very often they have these co-occurring medical problems and that they're equally important. One of the kind of pushes right now in the US is to address the fact that people with major psychiatric illnesses have a shorter lifespan than people who don't. And that's wrong. That we really need to address that. And the major reason that their lifespans are shorter has to do with really treatable medical problems. It's not because of suicide, it's not because of homicide, it's because of hypertension, it's because of heart attacks, it's because of lung cancer. So we really want to be, and it's because of diabetes-related complications. So we really wanted to put something together that mingled coping with your psychiatric illness at the same time as coping with your medical illness. They're equally important. So that's called integrated IMR, in the fact that it's integrating the medical and the psychiatric. We also did an IMR for forensic clients, people who have involvement with jail or prison or the criminal justice system in some way. Is that because we know that that's often, especially when people do not have good treatment for their illness, they end up in trouble with the law, as one might say. And we want to be able to approach those folks and teach illness management skills to them in order to reduce their psychiatric problems, but also to reduce the chance they might have to be sent back to jail. So we integrated those two things. We found that that was very useful in terms of helping to approach these folks just a little bit differently. One example is that people who are in prison learn to be very self-contained. It's not a good idea to talk about your feelings to your cellmate or to the people in the general prison population, because you might become a victim. You might become, makes you more vulnerable. So they get in the habit of not expressing their emotions or their desires or their wants. And yet here we are in IMR saying, go ahead. Please talk about the things you're interested in, the things that matter to you. So we have some suggestions in the illness management recovery for forensic clients, some suggestions about how to approach that kind of push-pull situation. People want to be involved in recovery, but they're nervous. And it makes sense. If you I visited a prison on more than one occasion and also worked in the forensics unit of a state hospital. Very squashing, that's not a very good use of word, but squashes people. Makes them feel like they can't expand. And we're asking people to expand. We also did an extensive adaptation for persons with intellectual disability, with more high-functioning mental disabilities in terms of their intelligence. And we adapted the program for a program in Philadelphia called JEVS, Jewish Educational and Vocational Services. The reason I say that is that sometimes our materials, they call it the JEVS model. But it's really, we're proud of that because the persons with intellectual disabilities and psychiatric disorders are often shunted aside because people feel like they don't know how to work with them. So we took the illness management and recovery handouts and simplified them, made them a lot less reading, a lot less word-oriented, and more about actions, more about trying things out, more about role plays. And those materials are available free of charge. If anybody's interested, you can email us, and I'd be happy to send those to you. But there's simplified educational handouts, but we thought that the clinicians needed more guidelines. So that's the way that one is structured. Another adaptation we've done is enhanced IMR for co-occurring psychiatric disorders and drug and alcohol problems. And we're very excited about this. Even as we speak, they're sending it to the printer in Minnesota. And we made changes to the modules because when you think about integrated treatment for dual disorders, you talk about treating both at the same time. And what we wanted the handouts to do was addressing both situations at the same time. To have the handouts speak about recovery strategies also refers to substance use. So the handout about stress vulnerability also talks about substance use. The handout about social support also integrates substance use into it. So these are just some examples, and we'll just pick a couple to go through, but you'll see for each module we made changes so that it was addressing both things at the same time. So I'm just going to say that, for example, coping with stress, Module 5, which many of you are familiar with, we now include information about how both substance use disorders and psychiatric disorders are subject to stress, and that many times people cope with stress by using substances. And so we wanted to kind of weave that in there as well. Okay, let's see another one on this one. In healthy lifestyles, we had no additions because healthy lifestyles is the same across the board. But in terms of making a plan to stay well, what we used to call that module reducing relapses, is now we realize we need to add information about not only how to avoid psychiatric symptoms coming back, but also how to avoid substance use from coming back. Okay, so if you were thinking of adapting an IMR for a special population, I would just say that it's important to think about adding educational handouts where they're needed. So if you're working, say, for example, with persons with PTSD, you'd want to have some information in there about what is PTSD and what are the symptoms of that. If you are going to be including more individuals with borderline personality disorder, which is a challenging area, is you'd want to have some practical facts about borderline personality disorder. And you might want to add more coping strategies, things about boundaries, things about being able to regulate one's own emotions. So there's some gaps in IMR that you can fill with the educational part and add strategies to. Okay, so I'm going to, let's see, I think it's almost time to switch for, we're really hoping you guys have some questions for us. I can't, sorry?
I have a question here.
You have a question? All right. There's a question from the audience.
Let's do it.
He looks familiar.
I think, why don't you spend 5 more minutes on that, and then, well, we'll answer the
Okay.
question while we're setting up this video.
Okay, and then we since we mentioned that video about the graduation, we'd like to be sure to show it. So we'll, while we're answering some questions, they'll be helping us to set up that video. But one of the areas we wanted to talk about was what do we think might lead to successful implementation of IMR. The philosophy is important, the mechanisms of how we deliver it is important, but what keeps things going and keeps things successful? We think it's real important to involve agency leaders and agency administrators from the beginning, is that talking with them, getting their, we would call buy-in. What about IMR might be valuable to them as their agency director? What is it that we need from them? What are some things that they might have some stereotypes even about what's helpful to provide to persons with psychiatric disorders? And kind of lay out the ingredients that you need their help with, because it really does take a village to do IMR. And if you as practitioners, as IMR clinicians, don't have the support of people higher up, it makes it very challenging. So if you can start with having the buy-in from the agency leaders and also from the national government, and that's why I'm so delighted to see the Minister of Health here. It's so important to know that there's that support from the top down and also from the bottom up. Is you want to be able to have both parts of that. And I think to do that, just some practical ideas is you are working with clients is to also real frequently update the agency directors. It's a little bit like we can fall off their radar. And so if you want to keep showing your face. And so having the team leader of the IMR, having a meeting with IMR leaders to say, this is what we're doing, this is some of the progress we're seeing, this is some of the goals some of our clients are accomplishing, that gets their attention, the agency leaders. But if we don't bring it forward, they're not going to know about it. So I would say to try to meet with them maybe monthly, and to also to invite them to things. Invite the agency leader to an IMR group sometime. Or invite the agency leader to when you have a celebration, like a graduation of IMR participants, or when we encourage things like parties, a holiday party, and invite clients and families and staff from various parts of the agency, including the agency leaders. Another thing that we think is a good factor for success is having you all be part of an IMR team. That you're not the only person at your agency who's doing IMR. It kind of helps to have a team approach and to meet regularly as a team. We usually encourage weekly meetings and talking about various successes that you're having as IMR practitioners, but also challenges you might be having and putting your heads together about those challenges. A third thing we think helps with successful implementation is kind of monitoring, how's it going? Are we still following the model? Are we making the gains that we hope to make for the clients? And I would say that using the IMR scale is very valuable. How many here are familiar with the IMR scale? Ooh, lots more than we're familiar with the IMR videotape. Okay, that's great. And I like it because not only is it a tool for kind of evaluating how are we doing, but it's also evaluates how do the clients feel that they're making progress, and how can we adjust what we're doing to do better at that. So for example, if you get an IMR scale back and it says, in the past month, I have identified no recovery goals, and it's 6 months into IMR, not good. So you're going to want to readdress recovery goals with that person. Or if someone says that they feel like they don't have good strategies for coping with stress, good information. That's something then we're going to want to readdress. And to keep IMR fresh. Some people say, well, it can get repetitive doing IMR over and again. I think that the personal goals of clients, for me, keeps it fresh, but there's other things that keep it fresh. One is inviting guest speakers. We had one agency in Oregon who would invite folks in from the community to give, like little talks. One was on rescue dogs. They were very interested in how could they get a pet and what was involved in adopting a pet. And they had someone come in from the local Humane Society. Stay abreast of new developments in IMR keeps things fresh. Having this conference is very exciting, and having more things that help you understand what's going on that might be new. And I would also say that sustaining interest is important. If the clients are interested, they'll kind of keep asking you about it. So when's the next IMR group happening? So the more enthusiasm you get among the clients, the more likely the practice is to be sustained. I think we're going to go a little bit more directly now. There's lots of things in here about, I would say one of the things we do is having a certificate at the end of each module, where people get a certificate for completing a module. And they also on that certificate, there's a spot for them it says, congratulations for completing this module. What were the things you got the most out of this module? So they fill in part of their own module certificate. And then also having celebrations periodically, like at the end of every module, bring in some kind of special treat. Like at the halfway point, celebrating. We had one agency in Connecticut that had a family dinner the night at that 6-month point. It was things that we all need, little things that keep us fresh. And then so while we're taking questions, we're going to show you an example of that graduation that I mentioned. And I will say in advance that it might be a little hard to understand the English at times because as you well know, there's so many different accents in America. And this is, we hope that what actually comes across is not necessarily all the words, but the emotions that they're feeling as they graduate from IMR. Okay. So let's hear some questions. We got one to start us off from this gentleman in the black suit.
Before we go into the questions, I wanted to bring up one other thing about the sustaining of interest and so on, which is that, and this is relevant to the video, which is in some places, centers have found it very useful to have, and I mentioned this earlier, to have a service user who has completed IMR, then become a co-facilitator of IMR groups.
Like a co-leader. Mm-hmm.
A co-leader. Mm-hmm. And so one of the things about IMR is that the more people who get invested in it as a program, as a recovery promoting a service, the more stability and life it's going to have at an agency. And that includes clinicians, that includes people who are in the hierarchy of decision-making in the agency, like supervisors, like agency directors, maybe even a regional mental health administrator. And that also includes the consumers, clients themselves, so when they have a role, and even families as well. So that becomes another way of sustaining interest and continuing to grow IMR,
Absolutely.
as we had mentioned.
I agree with that. I absolutely agree.
So here's the
Yes.
question. In fact, I'm not going to, I read it before, and it brings up a great question. And the question is about the leaders or the co-facilitators of IMR groups themselves setting personal goals in an IMR program and periodically updating and talking about their own progress towards personal goals along with clients doing the same thing. And the person who wrote this described it as a very interesting experience being a clinician and being asked by an ACT patient about her or his poor progress in working towards his steps since the last IMR session.
So the client asked the clinician, why aren't you making more progress towards your goals?
Right.
It's
And
good.
this is a strategy. The strategy of clinicians who are co-leading an IMR group, themselves setting goals and sharing progress towards those goals. This is a strategy that we are familiar with and that we do know that other leaders of IMR groups have done and have found that it's helpful.
Thank you.
Susan may have some specific examples.
I do.
It's up to clinicians in terms of what they feel comfortable with doing. But when we teach IMR to clinicians, the way we teach it is by having people set their own goals in role-playing, practicing with another clinician. And when Susan and I, when we do 2-day trainings in IMR, we'll have people set goals, and then the next day, we'll have a little follow-up. You know the 6-6-6 rule, right? 6 months for a long-term goal, 6 weeks for a short-term goal, 6 days for a step. And now we have one more 6 for the 6-6-6-6 rule, and that is a micro step is a step that you can make progress towards in 6 hours.
No, 6 minutes.
6
6 minutes.
Well, is it 6 minutes or 6? Well, in any
I
case,
do 6
we
minutes.
have
You're more generous.
well, we have people set a goal that they can then take a step towards the next day.
Yes.
And so having people, leaders themselves set and work towards goals, in a way levels the playing field. It says, hey, we're all working towards personal goals. And by using as a way of example, and even by taking feedback from people in terms of steps, I think it's a very useful way in showing really that helping people make steps towards goals is just a part of
Universal.
life. It's not a part of having a disability. Do you have any examples of?
Examples, yeah. One leader set the goal of getting back to playing basketball. It was a woman leader in New York City, actually. And she started she broke it down in what she thought were 3 short-term goals that she could really manage and the steps. And she wasn't making progress. And she discovered she had to break it down more, that the first thing she had to do was get in a little better shape in general before she went out onto the court. So she started doing regular walks at lunchtime. And the clients were encouraging her. And they said, well, maybe you should break that down even more. So God bless him. David Penn's, another example, is a leader who said he wanted to get into meditating every day.
Right.
And he set that as a goal, and he would check in with folks on how that was going. And he also found he had to break it down smaller than he thought. So it's a nice experience. It's some leaders say, I don't ask clients to do anything I wouldn't do myself. I wouldn't ask for myself to do. And so by setting a goal for themselves and breaking it down, it says that message. Yeah.
And on the positive side, I'd like to also mention, I mean, not that that isn't positive, but on the follow-up side,
Yes.
Dave Penn, who we've worked with and was also the person behind the individual resiliency training part of the Navigate program for first episode psychosis. 12 or 13 years later, after that IMR group,
Yes.
Dave is still meditating. So not only did he make progress towards that goal, but he's had some sustaining of it.
Yes. Okay.
So before we show the video, are there any questions that people would like to ask?
We did such a good job, Kim. I think
All
we
right,
answered everything
let's
possible.
show the video. But I think we should, after the video, let's just for a couple of minutes, just
Stay
talk.
for, stay for a couple
We'll take
minutes.
any other questions or comments that people have.
Absolutely. Thank you.
We have one question here.
Oh,
Oh, we do, great. Oh, yes, we forgot to say you could ask it in Norwegian.
yes. If you ask it in Norwegian, they'll translate it for us.
So I will translate for from the audience.
Okay, yes.
So what experiences do you have with the earlier patients as therapists?
Okay. So with younger clients who are younger, absolutely.
No, just when they had experience themselves. They were patients in the IMR training, and then they do it themselves.
Gotcha. Okay, so having people who graduated from IMR become facilitators.
Yes, right.
Yes, I'm trying to think of a real specific example. I think it was, do you have one right away?
Well, there's Pallavi. There's one example.
Yes,
Of
yes.
this is a kind of an unusual example, but this is somebody who developed after entering a professional career and being a researcher in PTSD. She herself developed schizophrenia about at the age of 35, and she developed really a very severe case of it. She'd lost her job as a assistant professor teaching. She had been married, and her family broke up. She was actually homeless for a period of time. I had worked with her before, and she contacted me. We sent her money, and we connected her with a colleague of ours in St. Louis who reached out to her, engaged her over a period of 6 to 8 months, eventually got her, she became willing to take medication. She got involved in taking medication. She then participated in illness management and recovery at actually the same place. Is she in the film? Okay.
She's in the film, but she's not speaking.
Okay, so she's at the same place that the film is. She went through illness management and recovery as a client, and now she works actually as a co-leader in that program. So there's other examples as well, but she's an example of somebody who had a very kind of severe setback in her life that happened for several years. And illness management and recovery was part of kind of her rehabilitation that has brought her back to functioning really, very well and working as a co-leader.
Yes, and there's other examples of people who did not have that kind of educational background, but became co-leaders of IMR and felt that their special contribution was helping people to feel not alone, sharing a little bit of personal information, saying how they used a strategy or skill would seem to be very reinforcing to the clients. Yeah, well, he uses that skill. I can use that skill. That person also would go out into the community with the individuals in the group and help them take a step towards their goal. That was another way they became involved with IMR as what we would call a peer specialist. So that's another example. Okay.
Right.
So let's show the film, if we could.